Septic shock is the extreme form of sepsis, and we need to be aware of the fact that 28-day mortality of sepsis is around 25%. And if the patient lands in shock, the mortality may even be higher, close to 50% or more. And just like sepsis, the septic shock also has evolved with its definitions. Earlier, we used to couple the need for vasopressor support, the septic shock, in the recent definitions highlighted the importance of metabolic abnormalities than the blood pressure as a number. So circulatory failure or shock is defined as the evidence of inadequate tissue perfusion with impaired oxygen utilization by the cells, and this independent of the presence of arterial hypotension. So the points to be noted are inadequate tissue perfusion and impaired oxygen utilization by the cells. So to see if there is shock or not, one, we depend on various numbers. And two, before the numbers, we depend on the clinical examination. Though the numbers, the physical windows of our body, three physical windows, that is skin, the kidneys, and the brain. The skin, you can see some changes secondary to the shock, that is mottling, prolonged capillary refill time, which has gained popularity recently, and the kidneys with low urine output, and the brain, that is altered mentation. Obviously, we take these look at these parameters to see if these organs are perfused enough. And if any of these signs are there, we can assume that these organs are not perfused enough, and we take them as surrogate markers that rest of the body is also in the same lines, though we can't see the heart and we can't see the lungs. The changing these parameters or organ functions would give us some indication that rest of the organ systems may also are affected in the same lines. And if you want to depend on hypotension, which is defined as mean arterial pressure of less than 65 millimeters of mercury, and systolic arterial pressure less than 90 millimeters of mercury, or if the patient is hypertensive and the current blood pressure is less than his baseline blood pressure by more than 40 millimeters of mercury, we define that patient to be hypotensive, and this is considered a part of shock. So what are the mechanisms of shock, and why is this causing shock? So there can be diminished venous return to the heart, and the heart is poorly contractile, and the vasomotor tone of the vasculature is diminished, and the oxygen utilization is impaired. These four are the most probable causes of shock as per the current knowledge about shock and sepsis. And we know the mechanisms involved in diminished venous return, diminished cardiac contractility, and why the vasomotor tone is decreased and vascular beds are distended, and the impaired oxygen utilization. So when we treat the patient, we know that we need to control the source control. That is, we need to clear the infection, where if we are fortunate enough to identify the site of infection. And then we need to start the antimicrobial therapy as soon as possible, as close as possible to treat the causative organism. And then we also have to understand that treating sepsis is not just hitting the organism causing sepsis. It is to save the patient's life, to sustain the patient's life till we come over the infection part. So the resuscitation, which involves both oxygen supplementation and fluid replacement, this is the most effective way of sustaining patient's life. And the hemodynamic resuscitation mainly depends on restoring the sufficient tissue perfusion pressure and normalizing the patient's metabolism so that the markers of anaerobic metabolism come back to normal or normal acceptable range. So what are the endpoints of resuscitation? One, you see a clinical improvement in patient's condition. So you look at the physical windows, skin, kidney, and the brain function, and see if the patient is improving. And also, you can measure the mean arterial pressure, and it is persistently or sustainedly normal. And the markers of tissue hypoxia, that is lactates, and if at all you have provision of measuring central venous oxygen saturations, you can do that. And also, you can look at the central venous to arterial carbon dioxide gap. So you have to take a sample of the CVP sample, blood from the CVP line, and also a blood gas. And you look at the carbon dioxide in both those gas analysis. And if the gap is more than 6 millimeters of mercury, your shock is still persistent, and probably you have to continue your resuscitation efforts. And of late, as I mentioned, capillary refill time guided resuscitation, which is found to be non-inferior to lactate based resuscitation, has gained importance in the recent surviving sepsis guidelines, and you can try that if we don't have access to lactates or blood gas analysis. So usually we can see the clinical improvement in patient's condition, we can measure the mean arterial pressure, and we can check the capillary refill time and come to some conclusion about the reversal of shock. So the resuscitation process obviously is based on the optimization of oxygen delivery to the tissues. And this oxygen delivery to the tissues should match the metabolic demands. And the the delivery of oxygen to the tissues would depend on the arterial oxygenation and hemoglobin concentration and the cardiac output. And obviously, these three parameters would give you idea about oxygen carrying capacity of the blood or the oxygenating capacity of the cardiovascular and pulmonary system. So the fluid administration is considered the first step in resuscitating the septic shock patients. But when you're dealing with sepsis patients with fluids, so when should you start and when should you stop? And when should you start de-resuscitation? When would you remove the additional fluids that you have given? And when should you stop de-resuscitation? These four are the questions when you're dealing with fluids in sepsis patients. And obviously, as with the physiology background, all of us can understand that too much or too little of fluid in the body is not good. If you look at the first portion of the slide here, in the initial part where the left ventricular preload is less, you can see that the stroke volume on the y-axis is low. And when the ventricular preload is increased with fluid resuscitation, you can see a steep increase in the ventricular stroke volume. And it continues till the optimal volume is replaced. And if you are giving too much of fluid on the higher side, you maybe because of over enthusiasm to get your patient better sooner, or, or, or with lack of assessment tools, you might end up giving more than required fluids, which may not be good for the patient. So you can see in the second part of the curve, and here, however much the preload has increased, the stroke volume has not increased. And probably this is where you should stop resuscitating the patient with fluids and just give maintenance fluids and not the resuscitation fluids. So when you come across patient with tissue hypoperfusion, we have to assess the preload dependence, and we have to see if your patient is going to respond to your preload or not. For these, there are static parameters or dynamic parameters. The static parameters like CVP is not recommended for assessment of preload dependence, and the dynamic parameters are supposed to be more helpful in assessing the patient's response to the preload. And if the patient is spontaneously breathing and there are cardiac arrhythmias and you are ventilating the patient with low tidal volumes, your dynamic parameters may not be of much help. The dynamic parameters, there are various dynamic parameters. I'm looking at cardiac output and the mean arterial pressure. So you have passive leg rising test or end expiratory occlusion test, and stroke volume variation or pulse pressure variation, or the SVC or IVC variations with breathing. These are the dynamic parameters that would help you in assessment of the possible response of your patient to your fluid challenge. So you can do a passive leg rising test or look at the stroke volume variation if the patient has an arterial line, and the pulse pressure variation, and then go for fluid challenge and see the response, what the response would be. So how should fluids be administered? So the fluid administration should be individualized, and the surviving sepsis guidelines, they have come up with initial fixed bolus of about 30 ml per kilo of fluid within the first 3 hours of resuscitation, and then with frequent reassessment of hemodynamic status. And we have to keep in mind that fluid overload is strongly associated with increased mortality. So you give the fluid, but only till the optimal limit. If you end up giving too much of it, probably you're not helping the patient. So the frequent reassessment of hemodynamic status should be done after initial assessment, and then if at all required, you might end up giving the fluid boluses in the maintenance phase as well. So the standard table, I hope you can see the numbers. So the biochemical contents of the crystalloids and colloids, and we are supposed to, the guidelines say that crystalloids and colloids are equally effective. And when you are looking at the various biochemical composition of the crystalloids, you can see that sodium chloride 0.9% is not much physiological or not much normal. As it is said, normal saline is not normal because the chemical composition is much different from the plasma where this fluid is added to. So you probably are giving something which is not very close to the plasma. And then Ringer lactate, Hartmann solution, or balanced salt solutions, which are supposed to be more useful. And we look at the guidelines anyway. And then you can also consider albumin, but the evidence is against starch as of now. There is definitive evidence against starches, and gelatins, the evidence is not very strong as of now. So what are the optimal fluids according to surviving sepsis guidelines? So crystalloids should be preferred over colloids, and contrary to the earlier belief that crystalloids are almost 6 times more, colloids are almost 6 times more effective than crystalloids. Now they're thought to be as effective as crystalloids or slightly more effective to the extent of 1:1 to 1:1.8, not 6 or more. Okay, so irrespective of crystalloid selection for infusion, we have to keep an eye on the chloride levels of the patient. So hyperchloremia should be avoided. And human albumin can be considered in patients who are requiring substantial amount of volumes of crystalloids. And the place of gelatins is not very clear as of now. But the hydroxyethyl starch should not be used because of higher mortality and higher requirement of renal replacement therapy compared to the crystalloids. And if there is anemia, you might go for replacement hemoglobin or packed red blood cell transfusion, keeping a target of 7 to 9. And there is no demonstrated benefit if the hemoglobin is maintained more than 9, unless the patient is actively bleeding. So this is various vasopressors used, and norepinephrine is supposed to be the most preferred pressor, followed by epinephrine, and also followed by vasopressin, and then epinephrine. And here this table gives you the maximum and initial doses of various pressors. And this, you can see the myocardial dysfunction when the patient is normal, and then patient is in early phases of sepsis. There may not be much drop in ejection fraction, but stroke volume is decreased, heart rate is increased, and then late phases, stroke volume is again decreased, preload is decreased. This is because of increased capillary permeability. And in resolution, capillary permeability is again better than before, and the preload is increased, and back to normal once the patient is better. So you may not be able to revert the sepsis in all the situations. Just with fluids and the pressors or inotropes, you may not be able to correct the shock. In those situations where the shock is refractory, you can think of hydrocortisone. The dose suggested is 200 milligrams IV plus or minus fludrocortisone. Levosimendan, we shall look at the surviving sepsis guidelines about levosimendan. Methylene blue, angiotensin, or veno-arterial ECMO. These can be considered if there is a refractory shock. So, so with this theoretical background, let us look at the Surviving Sepsis Campaign guidelines. Some of these slides are busy with too much of information, but we look at the salient points. Okay, so the SSC campaign, that is Surviving Sepsis campaign, recommends QSOFA compared to SIRS, MUSE, NEWS as a single screening tool for sepsis or septic shock. And also measuring blood lactates is suggested. And admitting patients to ICU within 6 hours is suggested. And infection, as you can see, the slide is busy, and it is recommended that rapid assessment and likelihood of infection versus non-infectious causes is done, and the possible sepsis without shock suggested time-limited course of rapid investigation, and if there is concern for infection, administered antimicrobials, antibiotics within 3 hours from the time of sepsis recognition. And if there is low likelihood of infection or without infection, it is suggested that antimicrobials can be deferred and the patient is monitored continuously. And if adults with sepsis or septic shock with high risk of MRSA, it is recommended to go for MRSA coverage. And if patients are at higher risk of MDR infections, using 2 antimicrobials with gram-negative coverage for empirical treatment over 1 gram-negative agent. So 2 agents are suggested. So you can go through the Surviving Sepsis guidelines, and the mean arterial pressure, the target mean arterial pressure is supposed to be, or you have to aim for more than 65 and not less than that. And the hemodynamic management, the suggested, the choice of the agent of choice is norepinephrine, and it is suggested that we don't wait for placement of the central line for starting the vasopressors. You can start it on peripheral line and then go for central line. So don't delay the initiation of vasopressors till we get central axis. And the initial resuscitation to go for 30 ml per kilo crystalloid in the first 3 hours of resuscitation. And it is suggested to use dynamic parameters over static parameters. And it is suggested to decrease serum lactates in patients with elevated lactate levels. So we have to repeat serum lactates if there is elevated serum lactate and make sure that it is reduced. And capillary refill time can be used as a guide for resuscitation, along with other methods of assessment of resuscitation. In long-term outcomes, we are suggested to involve the family in the assessment of the patient and discussing the patient in long-term goals of care and outcomes. And with ventilation and sepsis, as we all know, the low tidal volume strategy of 6 ml per kilo is suggested, and the recommended plateau pressure of less than 30 centimeters of water over higher plateau pressures. And when it comes to PEEP, higher PEEPs are suggested over the lower PEEPs. and we go for ARDS protocol when we are ventilating patients with sepsis. So, so this is a typical ICU scene. We see ventilator, organ supports, and with the clinician, we always work as a team, and the intensive care person being the most important in treating sepsis. The ICU team has to coordinate the care, initial resuscitation, and the de-resuscitation part of it, and the antimicrobial therapy. And team is always important, teamwork is always important, and you take the help of other specialists whenever necessary. And with this, I close my presentation.